So welcome to a special episode with Declan Scott, and I am excited today to introduce him. He's a proud Willimin Noongar man from the ancestral country on the south coast of WA, who not only passed the recent primary exam, but scored himself the only merit that was there. So well done. And just as I found it today, not only that, he did all this while being a father and a husband. And he literally started studying when his second kid was just a couple of weeks old. So amazing effort. Today, he'll be talking about one of his favorite topics in the primary exam, Infusion Kinetics. And the charities that he will be sponsoring are the Willimin Noongar Language and Stories, that aims to celebrate the arts and culture from the Willimin Noongar country, and the Gondwana Link that aims to reconnect country across southwestern Australia. So without further ado, Declan, I'll let you screen share and over to you.
Hey guys, how's it going? So yeah, I'm Declan. I'm, I suppose starting is, so I sat the first exam this year, and a lot of the, I suppose, success of it is from Stan's teachings through the Monash lectures, Anaesthesia coffee break, and through adrenaline memories. So when he asked me to come on, I thought, have to kind of go for it. I chose bolus and infusion kinetics, and although we've got kind of an hour and a finite amount of time, I think it's a bit of a messy topic, similar to some of the other more difficult topics like arterial lines and respiratory mechanics. If you can just get a few of the basic clear concepts drilled and just make a series of true sensible statements, then you're on your way, and I think that'll be a long way to success. Different to some of the more core topics like relaxants and inhalational anesthesia and things where the expectation is into the minutiae. Yeah, so just quickly about the charities, because I know you're all Patreons and you want to know that you're doing good things. Gondwana Link, yeah, it's like Stan's introduced, it's an environmental pursuit, and there's a couple of world listed national parks on the south coast, and they're separated by much farmland, which is degraded, and Gondwana Link purchases farms and then revegetates them to try and connect these kind of wildlife corridors. And the other one is one that I've been lucky enough to be involved in, so the Willimin project, which is kind of a grassroots community group that aims to teach and distribute Noongar language and culture along the kind of community on the south coast. I will ask people questions through the kind of session this morning. We'll go through a few kind of structure and tips and tricks to study. I know there's probably most of you are sitting next month, right? Is anyone sitting next year? No, okay. So look, there may be people who watch this in the future who are sitting in kind of some time. So we'll go through some kind of study tips for next month and those people who are just kind of starting up for next year. We'll go through one SAQ in structure in some detail, and then use another two SAQs as platforms for discussion of concepts. And then I'll ask some questions. Now you can black your screen out if you don't want to have questions asked of you, but I would say please, try to be involved. We're all I'm on your side. We're all on the same side here. None of this knowledge is innate. And all of us have points in the curriculum, especially early on a Saturday morning, where we're not quite sure. And anytime you get a question before the exam day that you're unsure of, that's a great opportunity, right? The idea is to just keep going through things again and again and again until you've been asked everything in every different way. And then when they ask you something on exam day, you're like, oh yeah, we talked about that. I've thought about it before. So yeah, please keep your screens on if possible. So just quickly, some tips going forward. There's two schools of thought. One's people who study from the learning outcomes, Mark Reeves kind of for the primary, and that's great. And the other is studying from the SAQs. And my feeling is certainly that the curriculum is so big close to infinite, that the only way you can triage like how much energy you're going to spend on different topics is via looking at the old SAQs, studying to them, and then knowing, you know, what are the topics that the examiners love to talk about. So if you were doing the learning outcomes, you might do opioids and do kind of equal time on each. But if you've been studying to the SAQs, you know, tramadol is one that they love to talk about. Ultrasound in the Viva, they've asked, you know, every sitting for the last 10 years. So that's one that if you're looking at the old questions, you'd know that that's one that you need to be all across. I think the most important thing is that you can expect, so, you know, next month, it's bang on 4 weeks away, isn't it, the exam? You can expect 8 to 10 repeats. That means like on Mac 95 right now with model answers and examiner reports is 8 to 10 repeats that will be there in your exam. You can take, I think, a lot of kind of confidence from this, that if you're familiar with the repeats and you've got essentially a rehearsed structure, that you can economically smash these in a way that's conducive to marking, energy efficient and time efficient. And the only trick is how to make sure that, say there's 10 years of new curriculum, a lot of repeats, I don't know, would there be 200 questions, something like that? So how do you in the next month and the next period become really familiar with those repeat questions? A strategy that we did in our kind of study group that I think is really useful, but there's a few different approaches, is a 1-minute exam. So basically, like, what's a highly efficient way to use 1 hour to rehearse your structures, identify any deficits, and cover large kind of portions of the curriculum is you basically generate an exam from Mac 95, do 1-minute questions, 15 minutes to time. So that's exactly what will happen on exam day, right? Like, you'll get your exam paper, you have 15 minutes and you can write kind of structures in that 15 minutes. And then I would pick the 3 questions that I'm most uncomfortable with and unfamiliar with and do them to time. So 3 10-minute questions, and then spend 15 minutes reviewing the exam reports or the model answers and see what kind of holes you fell in. If you do that like on a work day, that's a really efficient way of spending an hour. And if you do that multiple times on a day off, that's a way of covering heaps of the curriculum. And you'd be surprised, in about 2 weeks of doing that a lot, you'll start opening exam papers and being like, oh, like, am I wasting my time here? I'm familiar with all of these questions and I'm across all of these questions. And then hopefully, if you keep doing this, you turn your exam paper over on exam day and you're like, oh man, there is 10 questions there and I've got a structure to rehearse for them. And now I can reallocate my energy to the more tricky ones. Like, for instance, in our one, we had like adverse effects of sucks, antiemetics, blood-brain barrier, like all these questions that if you've got a structure to rehearse for, you can just, you know, put them down. And then there was a few tricky ones that were new, like the, you know, messy ones, kinetics and dynamics of opioids in the elderly, or something that was a bit of a disaster. And it was like, oh, I can reallocate a bit of energy on trying to scrape a 1 in this, this tricky one. Other than the kind of 1-minute exams, there was another 2 people in WA who both had, I think, very effective approaches. One was basically made his own Anki deck with the old SAQs and his structures on there. So he would just spend like an hour or 2 a day on Anki, look at the SAQ, write down his structure for a minute, and then look at his model answer. And I think that's another way of, you know, just becoming ultra familiar with the repeats. And so on exam day, at the end of the exam, he was like, oh, I just, for the whatever 9 repeats, I just verbatim put down my rehearsed structure. And I remember thinking, that is pretty strong, if you can say that. And actually, I don't think she'll mind me saying this, but the previous medalist had, who is a superstar, she had like hard copy flashcards that she'd made, just like a big deck with all the old SAQs out on one side, and then on the other side, her structures. So again, just like ultra familiar with the repeats. The other one is train how you play. So like we used to say, the best way to prepare for the grand final is to have a scratch match on the MCG in front of 100,000 people, right? So you want to be training exactly how you play. And I know Stan spruiked using the like the actual exam paper, because the spaced lines are really awkward. And like, use the pen you're going to use on the day, do it to time, do it with the real exam paper. So then when you get to the exam day, you've done it 20 times before and it's quite comfortable and familiar. I think, I mean this, I think probably 50 or 60% of the exam is content and the rest is performance stuff. On the day, you'll be real tired, you know, and how do you perform in a way that's conducive to marking, right? Like handwriting, get across the time pressure, communicate in a structured fashion. I think the only way to do this is to do practice exams. And again, our kind of cohort did, I'm not sure how many times we did it, but it would have been double digits. Everyone meets. So your study group, maybe there was 10 of us. Print a Mac 95 exam, do all the MCQs, have an hour break, and then do all the SAQs. And so that's covering a lot of curriculum and training, all the performance stuff. And so that's your fatigue, your handwriting, your exam paper, all these kind of things. And then how do you train the anxiety part of it? So what we did was we would all mark each other's answers, and that kind of puts a bit of an edge on it, because you want to be doing good answers when your friends and colleagues are reading your answers. But also marking other people's answers, we would allocate each other our weakest topics to mark. And then so you'd read, half a dozen answers of the question that you're least comfortable with. You would become really familiar with the exam reports and the model answers. And also, you're not going to mark your friends' answers, your friends and colleagues' answers, and say, oh, this wasn't quite right, unless you're completely across that topic. And so you pick one that you're bad at, and it forces you to read Nunn's, Miller's, the quite hard going chapters, and you can turn a question that you're not good at to one that you feel really good about. So like the end-tidal arterial CO2 gradient question that came up recently, that was one that I found really awkward. I picked that one to mark. So I had to read like 8 questions, mark them, read the chapter in Nuns, look at all the model answers, and it quickly changed it from like a weakness to one that I was more comfortable with. So I think drilling, doing exams as much as you can to time is essential, basically. This is probably more like leaning into Viva time, but it's useful as well. One of the old examiners at WA, so this has been echoed in like many different articulations, said the examiners are psychopaths and they covet what they see every day. The ex-chair of the council said, oh, the good candidates are the ones that are inquisitive in the operating theatre. And so what I think both of them mean by that is you've done your block of anaesthesia now, say a year of anaesthesia, and you know how things are, but you have to be able to explain why. So like a good example might be thiopentone. It's in a powder, but then you can dissolve it in water, but then you inject it into the body and the effect site, it must be highly lipid soluble. So how can it go from powder to water to lipid soluble? And you have to explain that through, tautomerization and the changes in pH. Why is something that you've seen every day, like Propofol's in an emulsion, but almost everything else is aqueous? Like, why is that? Could you make it aqueous? What kind of conditions would you make it aqueous in? The things that they'll ask you, especially in the Viva, things that you've seen 100 times every day for the last year, and then they'll ask you, yeah, but why? And you have to be able to explain. So that's a good exercise kind of with each other, especially around Viva time. So what I'm going to get you to do is, again, just to kind of reiterate the use of having a rehearsed structure. This is a question which, like, I would be baffled if this doesn't come up again in the next kind of 2 sittings. So it was asked in 2021. It's like really high yield topic with a lot of concepts that kind of overlap into another, lots of questions. So basically, I think good chance this will be in your paper next month, if not in next year's sittings. So take a minute and write down your structure for this question. I think this is one of the ones where it's a good example of if you don't have a structure that you're somewhat familiar with, it's quite a messy topic. And in the kind of heat of the moment, you'd be like, all right, what am I going to write? And the trap would be to fall into writing heaps and heaps and heaps of just like lists of things that slow awakening. And so verbatim, this is what they wrote in the examiner's report, and we'll flesh this out a little bit. But Jacinta, that was very strong, very strong. So an explanation of awakening, pharmacodynamic factors, and again, we'll like flesh this out a little bit, because I think, again, this is like highly likely to come up in your exam. If not, like it's something that they play on in vivas all the time. The compartmental movement and the effects of the duration of an infusion. So I think in your kind of opening statement, Jacinta, it was really good because you explained like what kinetically, when does wake up occur? You showed that you understood the compartmental aspect of it, and and you also showed the kind of laws of the world, right? Like things move down concentration gradients. So that's really good. I remember Mason, one of the previous medalists, gave a talk, and he said, often we start with definitions, right? And you don't know whether that's kind of conducive to marking or whether that's just to appease the examiner. And I think there's wisdom in that. But in a question like this, I think, like you said, like splitting it onto each page, I think if you had on your first page just like a few statements, 4 or 5 lines, that might take you a minute or a minute and a half, that says to the examiner, like you started, Jacinta, oh yeah, Jacinta definitely gets this. That is a great way to spend time. And it's not a definition of awakening, for instance, but it's the explanation of, hey, I get it. And so like, I won't tell you exactly what to say, but I thought like a series of statements on the explanation of awakening might be something exactly like Jacinta said. Wake up occurs when the effect site concentration falls below a threshold, and this threshold varies between patients. But I've written 1.5 mics per mil because a lot of the texts say that. But of course, that's different in everyone, right? And the decrement rate in the effect site is due to that concentration gradient, exactly like you said, from effect site to plasma. So that is awesome. And after cessation of the infusion, so this is like the essence of context sensitivity, isn't it? Depending how much drug is in the tissue, it will distribute from the plasma or redistribute from the tissue back into the plasma, ruin your concentration gradient and prolong wake up. And there's synonymous terms here, so I'll just kind of signpost this. You could say peripheral tissue, you could say V2, V3, you could say non-effect site tissue. Basically, it's the drug that's not in the plasma and not in the effect site. So I think, again, come up with a spiel that's relatively time efficient, but says to the examiner, hey, I get it. Like, it's all about the effect site concentration. It falls when there's a concentration gradient from effect site to plasma. And depending how much drug's in the non-effect site tissue, it can redistribute back into the plasma, ruin my gradient, prolong my wake up. Take you a minute and a half, but they read that and they're like, very good start, you get it. I can't remember how you articulated it, Jacinta, but I loved it. It was something about polypharmacy and like drug-drug administration or drug-drug interactions. I think when they said pharmacodynamic factors, and again, this is just my interpretation, right? But instead of saying pharmacodynamic factors, I changed this to threshold for awakening. So we've already said, like the texts all say 1.5 mics per mil, that's the effect site that people wake up at. But that's different in all the patients. And I think the threshold for awakening shifts for many factors. And if you're ever thinking, what are the factors that change something, you should just do phys-pharm-path. So the threshold for awakening will change for many reasons and vary between patients. For instance, phys-pharm-path, give one example of each. This is like a really economic way, and I think it's quite conducive to marking, and you don't fall into the trap of, hey, the threshold for awakening varies between patients. Here's a massive list of drugs that cause sedation. Like, don't do that. Do phys-pharm-path and write pharm, e.g. midazolam, and then move on, right? Like, this is your economic for time, economic for energy, very conducive to marking, right? Like the examiner turns the page and you say, the threshold for awakening varies between patients, e.g. pharm, midaz, path, brain injury, physiology, advanced stage. That's all you've got on the page. And they're like, good. Again, if you don't have this plan though, like you can easily fall into the trap of just writing and writing and writing and writing, and you spend all this energy and time and ink and it's not conducive to marking. That's another good thing about marking each other's work too, because you start reading other people's answers and seeing how they've like very effectively communicated ideas. And you also see, wow, that was really hard to mark. Oh, wow, that was really easy to mark. Do you know what I mean? Maybe I'll try write it like that next time. It's really helpful, hey? I don't know if you said this one, Jacinta, but I think communicating how long is the case, you know, and there's a lot of different ways to communicate this, but it's just like in my mind, uptake factors. So like when we talk about, again, this is the essence of context sensitivity. How much drug is in the non-effect site tissue? If you're a compartmental modeling person, which like we all are, but how much drug is in V2 and V3? When I turn off the infusion, there, you know, for wake up to occur, there has to be a concentration gradient from effect site to plasma, right? We said that. But there'll also be a concentration gradient depending how much drug is in the non-effect site tissue from the tissue to the plasma, and that'll redistribute and that'll ruin my concentration gradient. And so what are the factors that affect how much drug is in the non-effect site tissue? And you give a few, like if you say that in a statement, the examiner's like, ah, yes. And then you can just give a couple of examples. You know, like you can say, oh, Marshfer, Schneider, long case, you know, higher dose administered, something like that. It's a little bit like if you get a respiratory phys question and they're talking about hypoxemia, the trap is to talk about like diagnoses. If you say something like pneumonia, no, you're on the wrong track, man. You should be talking about like shunt, VQ inequality, low FiO2, hyperventilation, right? They don't want like diagnoses. They want broad strokes and structure. And you know, without saying, under your structure is a list of things, you know, like you say, the threshold for awakening varies between patients, e.g. co-administered sedative drugs like midazolam. And they know that you know there's hundreds of medications that can cause sedation and prolonged awakening. I think here in this section too, and so you've turned your page, there's another page. This is where you draw your context-sensitive half-time diagram, which sounds laborious, but for those of you sitting next month, I reckon you could draw this if it's just with Propofol pretty quickly, eh? And then you've communicated again, the longer the infusion, here's your context-sensitive half-time, the longer it's going to take for the plasma concentration to fall. And you've also put in words, because multi-compartmental model, there's more drug in V2 and V3, and it's redistributing back into the plasma. Again, it's like, if you've got these kind of structures rehearsed, like Jacinta had, she had in her mind like 4 pages, I'm going to put something on each page, you can just like very efficiently, very economically get through some material. And then the last one's elimination. Does anyone know what the clearance of Propofol is? One of the previous medalists said to me, like knowledge is underrated in this exam, which is a weird topic, right? But I think I was at that stage where I was like, hey man, if I memorize the clearance and the half-life and the volume of distribution and the PK of all these drugs, like I'm laughing. And in reality, that's not true, hey? Because I think if you know Propofol is a high clearance drug and you know what clearance is, it doesn't matter if you say 40 or 50 or 30 or 60 mils per kilo per minute, as long as you don't say it's 1 mil per kilo per minute. I think if you say it's a high clearance drug, you know, 40 to 60 or 30 mils per kilo per minute, and it's hepatic and extrahepatic, that's the money, right? It's not remembering the numbers. Although Propofol probably is one where you do remember the pKa and know it's an acid and know it's volume distribution and stuff, but it's you know what I'm saying. I think what they wanted here was, it's a high clearance drug, it's hepatic and extrahepatic. I think it's worth memorizing the mils per kilo per minute of clearance for Propofol, just because it's Propofol. And they did want this in the examiner report, unless your hepatic disease is advanced, its clearance is not limited by, you know, hepatic dysfunction. They didn't have this, but I think blood flow more important than function is like a worthwhile statement. You could also say in a kind of line or two that it's offsets by distribution after a short case, but we'll get into that in a second. So again, like I've just reworded for like the way my own brain works, but I think everyone should articulate it how it kind of fits best in their mind. an explanation of wake up, which also shows you understand compartmental modeling and that things run down concentration gradients, the factors affecting the threshold for wake up, the effects of an increased dose, duration, uptake. And again, what I really think that is, it's how much drug is in the non-effect site tissue, how much drug is in V2 and V3, and then we'll redistribute at the end of the case, and that it's a high clearance drug. I think that's enough for a pass, right? Like a good pass. And if you've got it rehearsed, that'll be fairly fast. Something that they had in the examiner's report that I'll just digress for a second into kind of a concept that I found interesting and often not discussed. The examiner's report said the highest scoring candidates discussed the compartmental movement after a short case versus a long case. And so in our study group, we had a thing, this concept comes up quite a lot actually, like washout after SIVO anesthetic, wake up of a morbid obese patient at the end of an anesthetic, all of the factors affecting wake up. I see a beautiful baby, a future medalist. So who wants to answer the next question? Should I just pick someone? Basically, the question is, at the end of an anesthetic, a patient with a high cardiac output, do they wake up faster or slower? Again, this is not the same thing, but it's an overlapping concept. So like I think the traditional teaching with a lot of these things is, oh, high cardiac output, that's, yeah, they're going to wake up slow. And I think there's levels of knowledge, right? Like you'd say when you're first on your like study journey and your like acquisition of knowledge, someone would say, oh, how's the cardiac output affect wake up? And you'd go, oh, I don't know. And then the next one would be, oh, high cardiac output, they'll wake up slower. And then the higher level is, oh, well, actually, like short case, long case, right? We used to say short case, long case. Short case, one thing happens. Long case, another thing happens. And then you've articulated to the examiner, like, I get, you know, the compartmental modeling, the concentration changes in V2 and V3, and actually cardiac output has opposing effects depending on the duration of the case. So that's kind of short case, long case. And I guess, again, the traditional teaching of a high cardiac output and a slower wake up is if you've got these reservoirs of drug. And so again, like reservoirs of drug, V2, V3, non-effect site tissue, you know, if you want, you can have as many compartments as you want, right? You can have muscle, fat, gastrointestinal tract, kidney, liver, lung, whatever. You could have 100 compartments. They're all at the end of a long case. They're reservoirs of drug, and their blood flow varies depending on the cardiac output, right? So if you've got these reservoirs of drug and you've got a high cardiac output, it's perfusing those reservoirs, and you've ceased your infusion. But then because you're perfusing these reservoirs, the drug will redistribute back into the plasma, ruin your effect site plasma concentration gradient, and prolong wake up. Now, if you've got a low cardiac output and you're not perfusing your reservoirs of drug, then those reservoirs are irrelevant, and your plasma effect site plasma concentration gradient will remain steep and your wake up will be fast. And this is certainly discussed a lot in the theories of wake up post like volatile anesthesia, but also the wash in, right? The partial pressure equilibration. If you've got a low cardiac output, it's like, again, this is overly simplified, but it's just taking drug to brain. Whereas if you've got a high cardiac output, it's taking it to muscle, fats, gut, everywhere. And so the partial pressure equilibration is slower. Again, like an overly simplified way of looking at it would be, how good would the system be if I could just inject propofol straight into the carotid artery? It would be so efficient. Imagine if I could waft sevoflurane just straight onto the brain and not go to all these reservoirs. Fast partial pressure equilibration and go to sleep, no reservoirs in the rest of the body, and a fast wake up. Just like Sarah articulated really cleanly and beautifully, if it's not a 12-hour flap, it's a 10-minute perianal abscess, then there's no reservoirs of drug, and the amount of drug in the muscle and the fat is low or no. So a high cardiac output will actually take drug from plasma to muscle, and it will distribute rather than redistribute and speed your wake up. I think if you do your like 4 points, and then you mention short case, long case, that's like a cherry on top, right? And I think they'll really like that. Also, think about this across a lot of the wake-up questions because it's relevant. Again, yeah, the case duration determines the amount of drug in the non-effect site tissue. Like, what's your reservoirs of drug? More drug in the tissue would redistribute, less drug will distribute, and the determining factor is how long the case has gone for. I'll give you another minute. This will be, we won't unpack this in as much depth as time, but we'll use this as a bit of a platform for some core kinetic definitions and discussions. But this is another one where it's kind of worthy to have a bit of a structure that you've rehearsed because it's a mess. Take a minute. All right, that's a minute. Does anyone want to share their structure? And like, I'll preface this with this question. I've picked it because it's a mess, this one. Like, structuring it is very difficult. Anyone?
So I'll go again if no one wants to.
Nice, Jacinta. I appreciate it a lot, man.
This is really hard. I don't like this at all, but
it is hard.
Split it into halves. And so my first half of the answer is to define half-life, do the equation, and then give examples of the significance of a short and a long half-life, and then repeat the same pattern with context-sensitive half-time, and then draw the graph of context-sensitive half-time on the last page.
I like the split. I think the split's the way to do it, hey? And like, just really signpost the like overlapping concepts and contributing factors. I think that's, yeah, I think splitting it seems to be the way to do it. But look, this one's going to be a platform for discussing concepts, not a structure. And I think this was more of a another thing to underline. Hey, it's really important to be familiar with the repeats, because if they ask you this question and you've never looked about it, thought about how you're going to structure an answer, it's going to come across like you've never looked at it before and you've spent 10 minutes where you're really tired and stressed trying to get something down. Like, that'll be conveyed. Another one, if you've marked this for like 10 of your colleagues, you'll see 10 ways of communicating things, and you can like pick the best one and copy their approach. So similar to what you said, I split them and said define forms, what are the contributing factors, the limitations and utility, and then draw the diagram. So again, I'm going to start asking questions now, and I'll just move through all of you. But if you've got your screen blacked out, I won't ask you. What's half-life? So it's definitely the time for the drug concentration to reduce by half, right? So like C to C on 2. But where that drug is, there's a bit of leeway about like where the drug is that the concentration's gone down by 2. I don't know if I've articulated that very well, but I guess I'm going to ask you a follow-up question. What half-lives do you know? So if I told you the elimination half-life of Propofol was somewhere between like 2 and 4 hours, or it's like 100 minutes to 4 hours, would you like, where is that drug? So I give you a milligram per kilogram, and then like the time it takes for the concentration to reduce by half is 4 hours, let's say. Whole body concentration, I guess that's what I'm trying to say. So distribution is plasma, elimination is whole body. And then so like one last question. I know I'm kind of hammering you here, but this is good for all of us to get really crisp. And I will say this was actually a viva of mine. Like, it was a Propofol bolus plasma effect site concentration diagram, and they would just like flew through questions with me. So if we talk about elimination half-life, so the time it takes for C to go to CO2, what compartment model would that be? If it's the whole body, it's a one compartment model. So like the body is one big jar. I put 100 milligrams of propofol into it, and the elimination half-life is 4 hours or 100 minutes, depending where your text is. It's the time it takes for the concentration to reduce by half. And so like, why do we talk about these things? Well, we'll get onto that when we get to utility and limitations, basically. It's an equation that succinctly describes the contributing factors to half-life. Do you know what it is? So I think for everyone, just to really drill home, this is like a good way, you're right. This is a good way of thinking about it, not just for like a succinct answer, but also conceptually. I find this really, really helpful. Even if you forget, or basically proportional to volume of distribution and inversely proportional to clearance. And I think this is like a key for a lot of the kinetics. So I think putting this down is useful. And so like, why is this conceptually useful? I guess in a multi-compartmental model, the clearance is from V1. And so if it's a high volume of distribution, like fentanyl or something like that, distributes out of the intravascular space and is not cleared from there, is sequestered in the peripheral tissue, like Isabel described. And then if it's got a high clearance, it's going to have a short half-life. And like, what are the implications of that? So what's the utility of half-life? Let's say elimination half-life. The differential between half-life and observed duration of clinical effect is a good concept to be thinking about. I think that's really strong. I mean, can anyone think of any other like utilities? And it doesn't have to be for, I think when we think about our drugs, like IV anesthetic agents with a high volume of distribution, we move away from half-life because of the limitations. But put your medical registrar hat on now, like what are some of the utilities of half-life? Depending on your drug depends on its utility, right? And I think that's, again, the like levels of knowledge. If you said like antibiotics, anticoagulants, things like these are often dosed on half-lives, like I'll dose at 1 half-life. If you had a drug like, again, like the combining factor of the uselessness of elimination half-life with a lot of our high volume of distribution drugs like Propofol and Fentanyl. If you had a drug like adrenaline with a low volume of distribution and a high clearance and a short elimination half-life, like 90 seconds, you probably could dose it on half-lives. I'm going to give a bolus every 90 seconds. That sounds pretty reasonable. Also, antibiotics often dosed on half-lives, things like that. Another one is time to steady state, exactly like you've described, Kate. That was really good. Five half-lives to steady state. I think Ahmed already introduced the idea of the limitations of half-life. I think the broad strokes answer would be the correlation of elimination half-life and observed like duration of clinical effect is variable. Again, we said like Propofol's elimination half-life is like 100 minutes, maybe a few hours. If you get a milligram per kilogram bolus of Propofol in endoscopy, you know, what's the relevance 4 hours later? Like, it's completely irrelevant. Like, a minute goes by, they might shut their eyes, drop their respirate, transient apnea. A few minutes later, they've opened their eyes, they're starting to wake up. 10 minutes later, they're awake. An hour later, it's like they've never had any Propofol. And again, it's because it's a one compartment model, right? Like, that's the amount of drug in the whole body. But if it rapidly diffuses out of the intravascular space into the effect site, but also everywhere else, and then equilibrates, well, like, who cares after a bolus what the concentration of Propofol is in the left quadricep? It's absolutely meaningless. Okay, what is volume of distribution? Why do we say apparent? It's basically just the factors that cause a drug to leave the intravascular space, right? Like, I give you your 100 milligrams of Propofol, I check your plasma concentration. Oh, wow, in a one compartment model, what's the volume that this Propofol's gone into? So like, what are the pharmacological factors that are associated with a large volume of distribution? The pharmacological factors, I think most people will be able to reel off, and I think you did really well, right? Small unionized, lipophilic. Those are the ones you want to be saying. It's really good. The patient factors comes less readily to people's mind, and I think it's more of a like just a good exercise to be moving in that direction. Again, like levels of knowledge for well, we quote these figures for volume of distribution, but really it's probably a dynamic factor between patients, and even may change in the duration of a case, right? Like one patient, their volume of distribution for a drug might change during a case. Can you define clearance? Can I follow up with a question? I think this was a multi-choice in our exam too. So like, what's the difference, or how can you link? I'm trying to ask this in a way that's not like read my mind. Elimination rate, like drug elimination rate and clearance in a first order system. So like a first order system, can you link them? So like clearance, a couple of things in the definition should be, so you're right, it's the volume of plasma from which a drug is irreversibly removed per unit time. So like a question could be, if I give you some propofol and it leaves the intravascular space and diffuses into whatever, the muscle, is that cleared? And like the answer would be no, because clearance is irreversible. It's the irreversible removal of a drug. And so propofol, say it's 60 mils per kilo per minute, that's the irreversible removal of drug in the plasma per unit time. Drug elimination rate, so the amount of drug that is removed from the body, is clearance multiplied by plasma concentration. And again, like it's a first order system is because it's like, say the plasma concentration you've been running, I don't know, 3 mics per mil, but you remove 60 mils per kilo per minute. If you go to 5 mics per mil or 2 mics per mil or 10 mics per mil, it will remove 60 mils per kilo per minute multiplied by whatever the mics per mil is, and that's your drug elimination rate. Yeah, and that was a multi-choice, I think. So like a nice one for us to have, you know, you're thinking about it now, not in a month's time, basically. Define context-sensitive half-time. Just as an exercise, can you draw the context-sensitive half-time diagram, and how many can you get on there? Great, very good. And so again, like levels of knowledge, I think defining it and drawing the diagrams, awesome. The next one is describing their shapes with that concept of like volume of distribution and clearance. So like, what's the volume of distribution of remifentanil? I think, again, 0.4 sounds fine. If you say it's small and you say 0.3, 0.5, 0.4, that's perfect, right? What about its clearance? So I think like, although we said memorizing numbers is not that useful, I think you've done very well there. And there's probably like a few drugs like propofol, remi, that you should remember. And I think you did really well there. So I think you can explain like the difference in the context-sensitive half-time shape between propofol and remi simply by being like their clearance is the same, but their volume of distribution is vastly different. And then fentanyl again, right? Volume of distribution is high, clearance is low, and try to explain the different shapes. I picked this one. It's not like a recommended text, right? But it's got dexmedetomidine on there and ketamine, and a lot of the like older ones don't have them on there. And I think they're increasingly popular to discuss in the exam. But fentanyl is interesting because in boluses and infusions, it displays context sensitivity. I think the key points here are with a short infusion, so sub 2 hours, it's offset still by distribution. If you give a bolus, one bolus, or you give a short infusion, it's offset by distribution.
Yeah.
And remember, context sensitivity is the time that the plasma concentration falls by half after cessation of an infusion. And the tissue has a high capacity for fentanyl. So if you run a short infusion and then turn it off, it's offsets by distribution.
Yeah.
At the 2 hour mark, when it like ellipses our fentanyl, it's because you've established a reasonable tissue concentration and now you maintain your plasma concentration. Towards the top end, like 5 hours plus, now you turn off your infusion and the drug's not distributing from plasma to tissue, it's redistributing from tissue to plasma.
Yeah.
And so fentanyl is a really good one to think about and explore. And so we will. Okay, so you're working in a trauma center and someone's leg has come off and it's very sore and you give them a fentanyl PCA. How long until they get like meaningful analgesia out of the fentanyl PCA you've given them? I don't know what kind of specific textbook answer they want, but like I would have just, if you would have just said ages, I'd buy that. You know what I mean? Like if you've got some 100-kilo young bloke who comes in with an open femoral fracture and you give them a PCA without loading them, you've done them a significant disservice. Why do we load drugs? So if you load them, a couple, like fentanyl is pretty interesting. It's not just like a drug that we use every day and so they like to talk about it. It's like got quite a lot of interesting properties and behaviors. Does anyone know the elimination half-life of fentanyl? Just as again, like a discussion point. So the elimination half-life is 180 minutes.
180 minutes.
So does anyone know what morphine's is? So they're actually the same.
Oh.
But this is the point, right? Like the observed duration of clinical effect is far different. And fentanyl, although half-life is a fixed value, its observed clinical duration of effect is much different depending on the dose. And actually, even though it's boluses, fentanyl displays context sensitivity in bolus kinetics. So you give a high dose, they'll have a much longer, even like a context sensitive half-time with a large dose. So you give 20 mics every 5 minutes, nothing happens. You give 100 mics, something happens. You give 500 mics at the start of a cabbage, they get a really long duration of effect. And so again, elimination half-life, irrelevant for a drug like fentanyl, because that's the one compartment model where the body is one compartment, just a big cup, and the concentration in the non-effect site tissue is close to irrelevant. Whereas something like, so this is from Hemmings and Egan, which I think is probably the best recommended text for kind of bolus and infusion kinetics. It's really reputable despite fentanyl there being misspelled. You can see here, so this is y-axis is just rate of rise and fall of the effect site concentration, and this is for a bolus. So you can see fentanyl's, whatever it is, 600, 800, 900 times as lipid soluble as morphine, and the time to peak effect there is like 3.5 minutes, which is right. You give a bolus, goes into the plasma, there's a big concentration gradient from plasma to effect site, runs into the effect site, they get a bit of analgesia. As soon as there's a reversal of that concentration gradient, because it's diffusing out into all tissue, now your effect site concentration starts to decay. And once you fall to that sub-analgesic threshold, whatever, 2 nanograms per mil, something like that, the offset of effect occurs. Now you look at morphine, whatever it is, a base with a pKa of like 8.2, very low unionized fraction, it, again, at its most simplistic, you put it in somewhere and it stays there. So the extreme example would be intrafecal administration. So you could say the clearance of morphine is like 10 mils per kilo per minute. As we've described, it's cleared from V1. And if you put it in the CSF, it's not in V1 and it's got a low lipid solubility. So it stays there. If you put it in intrathecal space, you can have, respiratory depression up to 24 hours. If you put it in the plasma, there'll be a concentration gradient to the effect site and it'll slowly run in, but it will be maintained. That is high plasma concentration, low effect site concentration. It slowly runs in, but that concentration gradient is maintained. So again, despite them having the same elimination half-life, their observed duration of clinical effect is far different. And so what's the utility here? Well, we talk fentanyl versus morphine PCA and SAQs, but like more importantly, this is something of like clinical yield. If you don't load your patient with fentanyl and then you do a fentanyl like pain protocol in PACU, you've done them a disservice, right? Because 20 mics at 5-minute increments is like not going to help anyone unless it's like your old NOF patient. Like it's not going to help anyone. You need to load these drugs with a high volume distribution, or you should use a drug with low lipid solubility like morphine, so it maintains that concentration gradient. And so like my answer for why we load drugs would be, you want to establish a tissue concentration, which Annika said perfectly. So I give my 200, 250 mics intra-op of fentanyl and I maintain or establish a tissue concentration. So now there's drug in V2 and V3. My subsequent doses into V1 maintain and therefore maintain an effect site concentration. So again, that's why we're loading drugs. I wanted to quickly have the compartment model here. Now, I know you guys are probably all across it, but just in case people watch this in future who are sitting in some time. I felt like when I first, you know, like the curriculum's really tricky and some of the concepts are tricky and you don't absorb things and understand them until you're like third, fourth, fifth orbit around them. And I felt like my first 2 or 3 orbits around the compartmental modeling, I was like, what are they talking about? I think a few sensible statements about compartmental modeling. Firstly, this is all fugazi, right? This is all completely made up and fake. It's a mathematical model and it's a vehicle or a means for us to discuss the way the drug behaves. So like Propofol or Fentanyl is a multi-compartmental model because I put it in the plasma and it leaves. It goes to the effect site, it goes to the tissue, V2, V3. You could have as many compartments as you wanted. And I think a useful kind of thought exercise is, and they ask this in the Vivas, you've got a drug, how many compartments are you going to use when you do your compartment model? And like morphine, you could argue to have less compartments. For a lipid-soluble drug like Propofol, you could have as many compartments as you wanted, right? You could say, you know what? I love compartmental modeling. I'm going to have a gut one, a liver one, a lung one, a muscle one, a fat one. I'm going to have a 10 compartment model. It's all made up and it's just describing that, hey, for our drugs, elimination half-life with 1 compartment is clinically meaningless and the drug leaves the plasma. And then it's a series of, you know, the laws of the world, effects like concentration down to plasma, plasma to tissue, things run down their gradients. So we won't go into this question in detail, but again, it's just a platform for discussing some interesting concepts. This question is pretty cool, and I would, again, get you all to, we won't do it to time this time because I think we're close to running out. I would argue for you to do like columns here, kinetic and dynamic rationale for your dosing, and do, I don't know, kinetic, you could say the volume of V1, the volume of distribution at peak effect or the effective volume of distribution, and don't fall into the trap of talking about duration of effect, hepatic blood flow, elimination, right? Because this is all about loading and putting someone off to sleep. But when we talk about the kinetics of choosing a dose for Propofol, I wanted to quickly use this as a platform to talk about cardiac output and the effect on volume of distribution. So what's the blood flow to the brain? And so if we said like the cardiac output was like 5 liters per minute, and the brain was like 1.5 kilos, and so you had like 750 mils into 5 liters, it's like 15% of the cardiac output. This is just an oversimplification just for discussion's point. If none of it diffuses out of intravascular space, none of it's sequestered by the lungs, it all goes to the heart and goes to the left ventricle, the percentage of Propofol that reaches the brain that you give is like 15%, right? 750 into 5 liters, 15%. So you give 100 milligrams and 15 milligrams goes to the brain. So when I say autoregulation, what do I mean by that? And everyone draw the diagram. You know the diagram I'm thinking, where you tell me what map the brain is autoregulated across. The tissue controls flow, and the tissue can adjust vascular resistance to, you know, maintain uniform flow across a diversity of pressures. And, you know, there's myogenic and there's metabolic, and then other tissues have their own kind of mechanisms like tubulo-glomerular feedback and, you know, the hepatic arterial buffering response and all of these things. I think I'll show the diagram because I know we've kind of got an hour and we're about to ellipse that, but basically, yeah, I think, oh, nice one. Who's that that's drawn all the gas tensions? Very strong, I like it. So like a map of 50 to 150, if you say it's auto-regulated across that kind of, that range, it's like a favorite line, right? Like you've given 2 sticks of Propofol, NAP's 55, you say, don't worry, everyone. Flow to the brain's auto-regulated. You've got a young, fit 18-year-old and you've missed the cannula 6 times and they're really anxious and their cardiac output's 25 liters per minute. What's their cerebral blood flow?
750 mils a minute.
Perfect. So again, in the like spirit of compartmental modeling, I've given 100 milligrams of propofol. Every milligram of it has reached the left ventricle for some reason. The cardiac output's 25 liters per minute, but the blood flow to the brain remains 750 mils. How much has gone to the brain? So you've given 100 milligrams to the person with the 5 liters per minute cardiac output, and like 15% has gone to the brain. You've given 100 milligrams to someone with a cardiac output of like 25 liters, and much less has gone to the brain. Remember, it's auto-regulated, and the brain controls how much flow it's getting. So it's getting the same amount of blood, therefore propofol, but the cardiac output's changing. So the dose that you've given, and everyone's seen this before, right? Like your anxious young patient, they get 2 sticks of propofol and they're still awake, and you can't put the LMA in. And it's like, oh my God, I've given 2 sticks of propofol, 400 milligrams of propofol, can't put the LMA in. Well, like, how much of your propofol dose has actually gone to the brain? Your cardiac output's 5 times higher. All of that's drugged is going to the non-effect site tissue. And I think it's worth thinking about in bolus and infusion kinetics, where does the drug go and where is the effect site? Okay, so you've given you 2 sticks of propofol and you've messed around for ages and you've finally got the LMA in, and you give a big sigh of relief. And then you go to sit down and start doing your notes, and the blood pressure cycles, and now it's 70 systolic. And you're like, Jesus Christ, they were so tolerant to propofol to go to sleep and put the LMA in, but they're so sensitive hemodynamically. And again, like, where does the drug go and where is the effect site? Like, every milligram of that 400 milligrams has gone to the L-type calcium channels in the vasculature, both veins and arteries, and every milligram, not really, but a lot of it has gone to the heart and reduced the contractility, but only a small amount has gone to the brain because the brain is auto-regulated. So they'll get, you know, dilation of the venous capacitance vessels, and they'll get a reduction in contractility, and they'll get arterial vasodilation. But the effect site, because that's the effect site for like dose-dependent hemodynamic collapse, but the effect site for hypnosis, amnesia, and like softening of the airway is the brain, and the brain is auto-regulated. Okay, so like the opposite, the same patient's legs fallen off and they've bled heaps. They're conscious and their MAP's 55. What percentage of drug is reaching the brain now? And again, you don't have to tell me a percentage, you can just tell me like. And so we've all seen like these, you know, big truckie with a beard who drinks like 10 beers a day, and then he's critically ill and shocked and goes to sleep with like 3 mils of propofol. And you're like, what is going on? I'm sure this guy would have been 2 sticks of propofol normally. So this diagram's from Cam and Powell, and I think it's really cool, actually. It's not kind of esoteric. It's important for us. So once their MAP's dropping, and remember, like brain and coronaries is auto-regulated down to a MAP of 50, but the amount of blood at a MAP of 55 that's going to the non-effect site tissue, kidney, gut, liver, muscle, skin, and you've seen this, right? Like people are mottled and whatever, is much, much, much less, and the kidney and things will be getting low or no flow, and therefore getting low or no propofol. By the time their MAPs drop, their cardiac output's dropped a lot, but the brain is still auto-regulated. So they're still getting 750 mils per minute, and they're still getting, so the brain's still getting 750 mils per minute, but the cardiac output, let's say for simplicity of maths, has gone down to 3 liters per minute. So now instead of getting like 15% of your propofol dose, they're getting like 25%. And your anxious patient previously, they were getting like 3%. And so subsequently they go to sleep with a much, much smaller dose. Like what's the point here, right? Like we all know about reducing doses in critically ill, hemodynamically compromised patients, and that stressed young patients need lots more. This was more like a platform to discuss volume of distribution and how it's a dynamic factor in like one patient in one case. The volume of distribution of a drug can change. And so high volume of distribution drugs, you're trying to load them to establish a tissue concentration, and then subsequent doses will maintain a plasma and therefore effect site concentration for longer. But like, what's the volume of distribution of the drug? Say it's fentanyl or propofol with a high volume of distribution if they've got a low flow state. you know, the V2, V3, fat, muscle, whatever, has a high capacity for fentanyl. But if you've got a cardiac output of like 50% of what it was previously, well, none of the fentanyl's going there. And so the volume distribution is like a dynamic factor. Just to quickly recap, and then we might have time if anyone's got anything like, not like questions if you've got them, but also like things that you like to articulate. Basically, I'd say practice old SOQs under the most realistic conditions that you can possibly create, like train how you play, have prepared structures if possible. You'll just feel so good on the day when you turn your page over and be like, there's 10 questions that I know and I've got a rehearsed answer for, a rehearsed structure for. And I think that's the way to success, smashing the repeats. Elimination half-lives are like close to meaningless if the offset's by distribution. And it's very different to the observed duration of clinical effect. Although with repeat doses, drugs like fentanyl, their duration of effect can match elimination half-life if you've loaded the non-effect site tissue. And the duration of the effect site concentration is maintained by the plasma concentration and the gradient from plasma to effect site. And then indirectly, if you're trying to maintain a plasma concentration, the concentration in the non-effect site tissue